We shall now go on to Dr. Prachi Agashe, who's the head of the Pediatric Ophthalmology and Spin Services from Advanced Eye Hospital Institute. Am I wrong? From Navi Mumbai, Maharashtra. I don't know. Anything wrong?
Good evening, ma'am. Yeah, no, ma'am. I am a part of that hospital. So in Bombay, actually, we typically are attached to many hospitals, and we are not in only one institute. Yeah. So yes, I am a part, and I'm the head of the institute over there. That's right. So can I start my talk, ma'am?
Yes, yes, yes.
Okay. So thank you, ma'am, for the opportunity. And I'll be talking about management of dissociated vertical deviation. Okay. So dissociated vertical deviation is a part of the dissociated strabismus complex, which has three components, the vertical, horizontal, and the torsional component. The vertical component of it is labeled as a dissociated vertical deviation. As is seen in the video, we can see the eye moving from up to down. 5 facts to know about DVD. It indicates an infantile onset of strabismus. It may be associated with profound sensory anomalies. It is always bilateral, though it may be asymmetrical. It is more profound in the amblyopic or the non-dominant eye, and it may be associated with fusion maldevelopment nystagmus, previously called as latent nystagmus. So the clinical presentation is in the form of the patient presenting with upward deviation of the eyes, which may be intermittent or constant and is more during inattention. It may be associated with infantile esotropia or infantile exotropia or Duane syndrome. The patient may present with an abnormal head posture in the form of a head tilt or chin depression. Head tilt is present in almost 33% of the cases. The head tilt can be to the side of the DVD or a contralateral head tilt with an attempt to try to decrease the motor component of the DVD. Occasionally, the patient may try to achieve some fusion through the head posture. The sensory adaptations, they are very poor. Stereopsis is typically absent. Suppression is something that is very commonly seen. Peripheral fusion may be present if the deviation is less than 4 prism diopters and is something that is aimed at in the management. The types of DVD include committant versus concomitant DVD, wherein in committant DVD, it measures the same across the horizontal gaze in primary position, adduction, and abduction. While in concomitant DVD, the measurements vary across the horizontal gaze with a difference of more than 7 prism diopters. Asymmetric versus symmetric DVD is basically a vertical excursion that we measure in the primary position between both the eyes. As is seen in this video, the DVD is much more present in the left eye as compared to the right eye, with showing an asymmetric DVD in the left eye. So few tests to diagnose DVD is the Posner's maneuver, wherein when we place a translucent occluder to get the DVD manifested, when we place another occluder on the other eye, both the eyes get realigned. The red filter test is very characteristic, wherein the red dot is always seen below the white dot because it's a dissociative test, and the eye behind the red filter is always deviated upwards, and it's a useful test to differentiate from hypertropia. Wilczewski's phenomenon, again based on a similar principle, when neutral density filters are placed in front of the fixating eye, the hypertropic DVD eye tends to fall. So few tests to differentiate from true hypertropia is that the deviation increases under a translucent occluder as seen in the photograph, the red filter test I talked about. And in the alternate cover test, we see both the eyes moving from up to down, which is not there when a true hypertropia is present. Differences between DVD and inferior oblique overaction should be known. I have listed it in the table. The characteristic one is the V pattern is absent in DVD. Fusion maldevelopment nystagmus is present. In fact, it is sometimes a movement to dampen the nystagmus, and the refixation movement is very slow in DVD as compared to in cases of eye overaction. Quantification is done using the prism bar undercover test, wherein a base down prism is placed over the elevating eye, and the prisms are increased till the hyper movement is neutralized. Another test utilized is a simultaneous prism undercover test, wherein the occluder as well as the prisms are brought simultaneously to neutralize the deviation. Grading of DVD is as shown. So grade 1 is a small angle less than 5 prisms with excellent control. Grade 2 is up to 10 PD with poorer control. Grade 3 is poorly controlled DVD measuring more than 10 PD, and grade 4 is manifest DVD measuring more than 50. Management non-surgical is observation that no intervention for very small DVDs, encourage or enhance fusion or switch fixation by using techniques to manage amblyopia or certain dichotic exercises. The surgical management of DVD includes taming the vertical recti as well as the oblique muscles. I have tried to enumerate the scenarios and try to discuss the management. So scenario 1 is symmetric DVD with good bilateral vision with no oblique muscle dysfunction. The superior rectus can be recessed with or without addition of a Faden. The inferior rectus can be resected. We can go in for bilateral IO antero-positioning even though there is no overaction, and a 4 oblique weakening procedure as suggested by Gillian. Scenario 2, bilateral DVD with deep unilateral amblyopia. So unilateral procedure can be done in the form of superior rectus recession or inferior rectus resection or inferior oblique antero-positioning. Scenario 3, symmetric DVD with bilateral inferior oblique overaction with V pattern. So only a unilateral, the inferior obliques need to be weakened by using a resection with IOAT or a graded recession as enumerated by Madam. And when there is a concurrent hypertropia, then the SR recession of the hypotropic eye needs to be done. Scenario 4 is DVD with superior oblique overaction and A pattern. Here, bilateral SR recession alone may be sufficient when the A pattern is small. When it is larger, then bilateral SR recession with bilateral SO tenectomy can be done. And a 4 oblique weakening procedure can be done when it is associated with large angle horizontal tropias. So the doses for SR recession are as enumerated again over here. They range from say 5 millimeters to 9 millimeters. These are very unconventional doses of superior rectus recession, but work very well. And the good part is they do not induce a hypotropia. Another point to be highlighted is whenever we are doing a surgery for DVD, especially in long-standing cases, an FDT is must to rule out the contracture. So DVD is generally bilateral and requires to be tackled in both the eyes. Unilateral surgery may result in DVD being manifested in the other eye. Exceptions are in a severely amblyopic eye and asymmetric surgeries to be done where asymmetric presentations are present. A unique form of DVD is a hypotropic DVD, which wherein the eye deviates downwards. It's mostly unilateral, associated with vision loss or high myopia, and surgical corrections involves recessing the inferior rectus. So the complications of these surgeries could be lid retractions, anti-elevation syndrome, or inversion of the A pattern in the given procedures. So they need good surgical techniques to avoid these complications. So to summarize, DVD is a special ocular motility disorder with spontaneous upward drifting of the eye, indicative of infantile onset of strabismus. It is typically bilateral, though may be asymmetrical. Management is aimed to convert a manifest deviation into latent one and achieve some peripheral fusion. And surgery involves tackling of the vertical recti or the oblique muscles as per the presentation. Thank you.
Oh, that was wonderful and so well within time. Dr. Veena, do we take a question?
Only one question, ma'am.
Yes.
Prachi, do you encounter any overcorrection with IO recession with antero-positioning, especially in amblyopes?
Overcorrection? No, ma'am.
No. And you switch the fixation with +2 diopter lenses or any other method?
Which fixation is by amblyopia treatment wherein the vision is good, or I have used dichoptic exercises in certain situations where the deviation is otherwise less, or after surgery when we are getting some fusion and the asymmetricity of the DVD is very less. That is the only chance that a patient can face.
Thank you.